I suspect most of us are here today because we recognize the centrality of behavior. And as it turns out, I wrote a paper on this with David a few years ago where we talked about the notion of halfway technologies. And there's relatively few conditions in medicine where you treat and it's a one and done. Most have the flavor of we need to manage a patient's condition, we can control that. Hence the name halfway technologies, which was coined by Lewis Thomas many decades ago. And what's key to recognize about this is you need a clinician to recognize a patient has a condition. You need the clinician to initiate and intensify therapy where needed. And then, of course, you need the patient to do their part in terms of managing the disease, treating the disease, whether it be through lifestyle recommendations or medications. All of this speaks to the centrality of behavior. When you look at recent books published by Nobel Prize winners in behavioral economics, however, you'd say, well, behavioral economics seems to have figured everything out. These books have a lot of wisdom in them and have lots and lots of answers to many questions. You look at the spread of nudge units around the world and you'd say, wow, this concept has a lot of traction and a lot of governments around the world have figured out that these nudge units can really help them. But then you might ask, well, what's the problem? And I don't know that I would say there is a problem, but I see the field as at a bit of a crossroads, and so I wanted to highlight a few things. One is there's a very important paper, which I would suggest you read, if you haven't, by Stefano Della Vigna and Elizabeth Linos, that looked at the average impact of nudges published in academic papers as opposed to nudges in initiatives conducted by nudge units. And what you will note here is there's a big difference in the average impact that's reported. So academic papers, 8.7 percentage points or a 33% increase, keeping in mind that many of these nudges are very low cost. That's pretty phenomenal. However, when you look at the full body of work done by nudge units, you'd say, okay, that's much smaller, 1.4 percentage points or 8%. And the authors very carefully looked through very detailed data, very detailed records, which impressively the Behavioral Insights team had collected on all of their projects, and basically found there's a huge publication bias that drives much of this difference. So one of the things that's interesting, and it probably won't shock anybody, but academics tended not to publish their negative studies. And Elizabeth was telling me that the number of negative studies published by the academics was actually pretty close to zero, which is disturbing because we all know there's a distribution of effects and many of the studies probably were negative. Secondly, there's a difference in the nature of the nudges tested in academic settings versus nudge units. So the academics tended to test nudges that had bigger effects on average. Third, differences in sample size. This probably further contributed to publication bias since the academics tended to do smaller studies, so those tended to have more negative results, which then tended not to be published. So this is important for us to recognize. When you look at the full landscape, a lot of nudges are probably not as effective as we might think. Secondly, when we look at the NIH model, stage model behavior change, and this is sort of the idealized pathway that NIH would like us all to follow, you have a conceptually elegant idea, basic behavioral science. It advances to carefully done feasibility pilots. Then we move to efficacy trials in research settings, efficacy trials in real-world settings, then to effectiveness and dissemination and scaling. There are a lot of reasons why this breaks down. So a lot of academics do their work in this blue box in the middle, efficacy trials in which people are asked to participate, they choose to participate, nothing wrong with that. But when you think about where the breakdowns are, they tend to happen thereafter. So efficacy studies tend to recruit the most motivated participants. Often those are designed with those participants in mind, and that doesn't necessarily generalize to a broader population. And then finally, lots of issues around dissemination and scaling, because sometimes these studies, when they're designed as smaller studies, they rely very heavily on personnel, very dedicated people who are very committed to a particular idea, and less on technology. And of course, that doesn't scale so well. Third topic, so I was recently part of a National Academies panel And what this panel looked at was taking a critical look at the field of behavioral economics as it applies to public policy. And there are a few things that are interesting that came out. Because of the contributions of the field, it was widely agreed among the group that in terms of public policy and practice, that behavioral economics needed to continue to play a central role. Now that's of course not the concern. The concern was more the but. The field has not yet produced generalizable and implementable practice guidance and intervention design strategies for determining what works when for whom. So again, the scalability problem where a lot of really promising ideas, a lot of them don't really translate into practice. We don't have a really good systematic way of making that happen to a higher degree.